great start for us. So now for a complete change of topic. So our second speaker is going to be Jatinder Minhas, and I think we're going to just try and find you on here somewhere. Is that you? No, that's you. Yeah. So Jatinder is from my own department, cardiovascular sciences, and I have absolutely no say in the selection of this, absolutely no say in the selection of it, so it's completely biased. And Jatinder is the recipient of the Lauder Prize, and Ian Lauder, who was previous Dean of the Faculty of Medicine, as it was, College of Medicine, College of Life Sciences, it is now, is in the audience, so no pressure, and I think Ian's going to give the award at the end. So Jatinder, all yours.
Thanks very much. It's an honour to present to colleagues, friends, family, members of the public today on my doctoral work examining the effects of carbon dioxide on brain blood flow. So I'm going to begin by just talking about how we manage brain blood flow in a sort of broader fashion, and then talk about what happens when we lose control of that brain blood flow, a concept known as autoregulation. It's maintained, we autoregulate well. If we lose control, we don't autoregulate, and there are implications for that. I'm going to talk about some stroke subtypes, and a particular stroke subtype that I'm interested in, and one that we've pursued through this work, and then talk a bit about why I care so much about carbon dioxide in this context, and then how we've managed to translate some of this work to patient populations to try to improve outcomes overall. So the way in which we maintain brain blood flow is key, really. So at the bottom here, we've got the blood pressure that we measure on our arms using our blood pressure machines at home. And I suppose we all should wonder somewhat how, when that blood pressure goes very high, for example, when we're stressed or when we have high blood pressure, or indeed when it goes very low, when we have a severe infection or we've not had enough fluid on board, why is it that the brain can maintain an adequate amount of blood to prevent us from passing out? And the way that that process regulates is by maintaining a tight window of blood flow control, known as autoregulation. And this process should exist and function in between this window here, though obviously when there are extremes, there are implications for the brain tissue. And what that looks a little bit like is, this is the main blood vessels that exist within the brain, and there are several key vessels there, and there's a very tight supply here between the blood that comes in, the nutrients and the hormones, etc., that blood supplies to the tissues. And when effects, for example, occur to diminish either autoregulation or changes in carbon dioxide occur, these can affect that balance, and we can lose supply to the brain, or indeed gain excess supply without any positive effects. And one of the implications we can see here is a really devastating hemorrhagic stroke. So where the red arrow is, that's high attenuation. This is a CT scan, and it shows quite a large area of blood here. This is characteristic of what we'd call a hypertensive bleed. There's quite a large area where this arrow is of edema or fluid that builds up around that bleeding. And then we've got an effect, unfortunately, on what would have been at this stage the healthy side of the brain, with a mass effect pushing across onto the other side. And this would really cause quite a devastating and debilitating stroke for this individual. Now, there are two key types of strokes that we manage most often, and they're a blockage type stroke, which you can see up here. The main blood vessels occur, a blockage occurs in those. We get an area of dead tissue around that, and that's called an ischemic stroke. And we've got a bleeding type stroke here at the bottom, as I've just demonstrated on that CT scan. And unfortunately, even in this current decade, we're still having quite a large percentage of patients who actually die before they reach hospital with bleeding type strokes. And although they make up more of a minority, unfortunately there's a lot of inequity in the research that we do for these patients and the outcomes that they achieve. And just to give you a little bit of an example of that is, if you were to take somebody with a blockage type stroke and a bleeding type stroke, and they were to both arrive at hospital with exactly the same clinical features, so for example they were the same age, they had the same conscious level as they arrived, you're far more likely to receive no treatment or de-escalation of your treatment, a very sort of approach that's far more towards symptomatic control, comfort care, as opposed to the aggressive interventions that we see delivered, for example, clot busters, etc., in patients that have a blockage type stroke. And it's this inequity that's important to consider moving forward. So we in Leicester have spent some time looking at autoregulation impairment in patients that have bleeding type strokes. And we've managed to deduce that these factors are disrupted between day 1 of your stroke and day 12, and they're often associated with worse conscious levels and an overall higher risk of death. And the way that we've done this is by a carefully designed precision medicine protocol that includes many things: carbon dioxide monitoring, devices that measure beat-to-beat blood pressure, not just in isolation as we do with the machines at home, but every single time your heart beats we get a blood pressure reading. And we look at the relationship between that blood pressure measured here and brain blood flow using ultrasound. It's a non-invasive method. It doesn't require any lines or anything inserted into the skin, and it's very acceptable to patients in a variety of different contexts. And we've conducted studies in patients with Parkinson's disease, dementia, stroke, and a variety of other different clinical conditions. Now, why is carbon dioxide relevant? Well, the reason it's relevant is because studies from the late 80s demonstrated that when we aggressively drop blood pressure using, for example, a thigh cuff, so you block off blood pressure for a period of time and that then drops your systemic blood pressure, those patients that had the lowest levels of carbon dioxide conditions rapidly improved their brain blood flow, their cerebral blood flow, much quicker than those that had a higher level of carbon dioxide. And this demonstrated that they were autoregulating better in low carbon dioxide conditions. Now, how do you demonstrate a low carbon dioxide condition? Well, if you breathe a little bit faster, you hyperventilate, you drop your carbon dioxide levels, and it's something quite as simple as that, really, as an intervention that may be able to that would have facilitated this sort of study. So just to have a look at what that looks like in real time. So this is somebody who would have had their brain blood flow measured, and then not soon after it was initially measured, I got them to breathe a bit faster. And what I want you to keep an eye on here, this is the mean velocity of the main vessel within the brain, which is often affected when we have blockage type strokes or bleeding type strokes. And just have a look at this pattern here and how it flattens down. And you can actually hear the sound of that vasoconstriction and that lower velocity occurring. So this is just as they begin to hyperventilate, you can see the mean velocity dropping, they're vasoconstricting, they're gaining more control of that blood flow. And you can see the waveform changing. So what we designed first off was we took 55 healthy volunteers, and what we generated was a protocol designed to really test brain blood flow to its absolute maximum. So we gave them 5% inhaled carbon dioxide, 8% inhaled carbon dioxide, and then we hyperventilated them quite rigorously. So dropped their carbon dioxide level 5 millimetres of mercury below baseline, and then 10 millimetres of mercury below baseline. And I can tell you that 8% CO2 and 10 millimetres of mercury below baseline is quite uncomfortable, and the 55 people that did volunteer to be in our study, some of which are here today, I'm very appreciative. And what we concluded from that was that the behaviour of the blood vessels was so that the velocities were the lowest when your carbon dioxide levels were the lowest, but your autoregulation, governed by a quantitative index of how well you're autoregulating, 10 being the best, 0 being the worst, was much better in low carbon dioxide conditions. So over a good population of people, we've managed to demonstrate that there's some possible efficacy in hyperventilating individuals. And certainly the opposite was true, where your carbon dioxide levels are high, it was a negative state. You might think, well, how could we apply this to patient settings? Well, if, for example, you've had a very big bleed on the brain and that vessel is bleeding, it may be beneficial to constrict that vessel, prevent it from bleeding more, minimise the velocity in that specific vessel. Or indeed, for example, if there was an area where there was a blockage and you were suffering with the tissue around it, you could remove that blockage and increase the blood flow. And there are implications for both, and it needs to be carefully delivered, but that was the basis of our intervention. So we went through a number of steps during my doctoral work. I've mentioned some of them already. So the first was to understand the problem, look at what happens with autoregulation in hemorrhagic stroke. The second was to look at the devices. How can we measure it best on the ward? What's the most accurate? And we compared this face mask here to some nasal prongs. We looked at the relationship across the full range of CO2, and that was really proving the concept. And as part of that, we also looked at sex differences, because there is some effects on brain blood flow as estrogen changes, so pre- and post-menopausal states, and there's also some effects in individuals who are of younger and older age, so we needed to factor that in. And then we also looked at some quirks from prior literature that demonstrated that when we do try and hyperventilate just off the cuff in a simple setting like here, there are some dysautoregulatory factors that occur early on, and we needed to tease that out. But lastly, we took the bull by the horns with a really quite aggressive intervention designed to take patients that have bleeding on the brain and to hyperventilate them. And I can say that within the existing literature, there's certainly nothing like this. And as we explored this with international audiences, it was something that was of significant interest, largely due to novelty. So the protocol was as follows, really. We had a baseline of 5 minutes, and then we hyperventilated these stroke patients who were recruited within 48 hours of their bleed for 90 seconds. We then had a further 5-minute baseline, and we repeated this straight afterwards. And then we had a follow-up period at 10 to 14 days. And interestingly, as expected, the types of patients who did have bleeding on the brain who we recruited had fairly mild strokes with smaller hematomas, hematoma being the size of the bleed within the brain. But what we did demonstrate was that as we lowered carbon dioxide on the side of the brain that had their bleed, we significantly improved their autoregulation. And so for the first time, there's some suggestion that there is something that we can harbour within these vessels that we hadn't previously appreciated. And on an individual patient level, and I think it's probably important to bear in mind that when you have had a bleed on the brain, there's a significant amount of anxiety and concern and worry both from the patient and their family. And to engage in this sort of study really is quite something. So the 12 patients that participated, I'm eternally grateful. And what we did manage to deduce was that as we lowered carbon dioxide, as expected, we lowered the velocity, and that was in almost all individuals aside from one. And as we lowered carbon dioxide, we improved their autoregulation. So what we are demonstrating is that hypothesis that we demonstrated in healthy individuals could be confirmed in a disease state. And it just looks a little bit like this. As you lower carbon dioxide in this direction, autoregulation is improved in these individuals. And bearing in mind normal autoregulation is around 4, recruiting any available autoregulatory capacity that isn't currently being used could be something positive. So we were very grateful that this paper was then accepted for publication in the International Journal of Stroke to an international audience and received a number of prizes both locally, nationally and internationally. And so we took this concept a little bit further. So as well as looking at it in a confined group here in Leicester, what does the data show us across the world in all studies that have ever been conducted looking at carbon dioxide in patients who've had a stroke, both blockage and bleeding type? And what we learn is actually, strangely, patients that have had a stroke are slightly hypocapnic, so their carbon dioxide levels are slightly lower anyway. So that raised a question that we hadn't quite considered, which was, is this as a consequence of having some pathology on the brain that your carbon dioxide levels are slightly low, or is the brain trying to demonstrate some sort of protective mechanism to try to recruit some more autoregulatory potential? The only thing that was interesting was that the worse your stroke when you came in, the more likely you were to be hypocapnic. It doesn't answer that question, but it provides a bit more interest. So we've taken this forward further, and we're now collaborating with 3 key players within the field of both carbon dioxide regulation in healthy and disease states, and also individuals who are studying improving care for patients with intracerebral hemorrhage. So to conclude, there is some potential for us to recruit cerebral autoregulatory potential, and moving forward, we hope that this is something we can examine in larger studies. And this interventional manoeuvre, although bold, did demonstrate some potential benefit and provided us with a platform to move forward. It is a personalised intervention, and it's one that needs to be delivered in a safe environment, understanding the limits, as we did in this feasibility study. It does raise bigger questions about carbon dioxide measurement in acute stroke, and that's something that we're pushing for as part of an intermediate fellowship. And the timing of this is possibly, and we need to think about this in animal models, is when you first have your initial bleed, the earlier you can deliver a vasoconstrictive effect, i.e. aggressive tightening of that blood vessel, hopefully the less of the chance there is for that hematoma, that bleeding, to develop even further. So I'd like to say a special thanks to my 2 supervisors who I've known now for 7 years and have provided me with exceptional mentoring. Anything I've ever needed, they've always been there to support me, and I really appreciate that. My team just down below, and my parents, and all of the people that funded this work, because this is sort of at the cutting edge of where we are, and some of it is is really pushing the boundaries of translation from bench to bedside, and I'm really appreciative for everyone that supported that work. And I think the last message really is my gran had a hemorrhagic stroke in her 60s, and she's now in her late 80s, and I'm very grateful for every day she gets to spend with her great-grandson. And I just hope, hopefully in the future, more families will have positive experiences like we've had. And although there is room for ensuring that people have comfort care if their hemorrhages are very big, there is a subset of people that I think we can do better for. Thanks very much.
Fantastic message at the end. I think that's really important. Questions? Okay.
Hi. Thinking about the potential of vasoconstrictive agents, I didn't quite catch the link between the vasoconstrictive agents and the carbon dioxide level. Could you just clarify?
Yeah, so there's a sort of a dose-response relationship between changing carbon dioxide from as we would normally be breathing in this instance. And if you were to increase your carbon dioxide levels, you would vasodilate somewhat. And if you were to lower your carbon dioxide levels, you'd vasoconstrict. So the video I showed was someone quite slowly breathing a little bit faster. And the way we do that is quite simply with a metronome. So for those of you who are musicians, a simple chord metronome, we set the beat a little bit faster than normal breathing rate. And then the patients will reach a sort of steady state breathing to that beat. And that will give us that 90-second sustained hypocapnia.
Yeah. Very interesting. You've demonstrated a very interesting physiological effect, mostly in normal, healthy volunteers. The question I've got is, to what extent is the effect compromised by pre-existing vascular disease?
Yeah, so this is an important question. So carotid stenosis, intracranial leukoariosis, so small vessel disease, blood pressure lowering medications. I think these are all important factors. One of the questions we asked ourselves, even in the context of a healthy population, is what is healthy? And we actually concluded as a department that someone in their 50s who's recruited to the study on one antihypertensive probably constitutes the healthy cohort that exists nowadays. In terms of scaling this up, clearly we need to know a little bit more about what the brain health is like at baseline. And I agree with you that certainly from our studies where we've looked at those individuals that have significant carotid disease, that will have an effect on brain blood flow. But the answer to that specific question in this cohort is we're not sure. But there's some interesting work, certainly I've seen some recent work from China looking at the response of the carotids and shear stress and other things to carbon dioxide change. And the response is not just confined to the brain blood vessels. There are some changes that occur within the neck vessels as well. So I think there's certainly some interest moving forward.
One more, if anybody wants to ask. Don't be shy. He's a professional. Okay, no more questions. Okay, so can I ask Professor Rawdon to come forward to do the necessary? I'm going to withdraw, but we will get a shameless picture of you this time on the Doctoral College website.
I started this university 36 years ago, and I thought until today I'd be to every single lecture theatre on this. This is completely new to me, so it just shows you how wrong you can be. Anyway, that's actually fascinating, and many congratulations for your work. I'd like you now to formally present you with the Lord of Prize. There's a medal there and a certificate. Very well done.